A macular hole, as its name suggests, is a break in the retina around the area of the macula. If you can remember, the macula is that area right in the center of the eye where all the cone cells are, where the best vision is. If you get a tear in the retina, you get a macular hole. So why does this happen in the first place? There are a number of causes, but one of the most common causes is pulling of the vitreous humor on the retina. Normally, the vitreous humor is attached to the retina. If it pulls on the retina too hard, the retina can tear and you end up with a macular hole. First off, let's go on to a bit of epidemiology. It's more common in elderly female people, just like age-related macular degeneration, and it's more common amongst people with myopia. Therefore, it's also very common in Asians, because Asians, compared to other ethnicities, have a genetically higher risk of having myopia. Another risk factor for macular holes is having a macular hole already. So, if you have a macular hole in one eye, then you have a statistically higher risk of getting another one in the other eye. On the other hand, if the vitreous humor is completely detached from the retina, then you have a very low risk of getting a macular hole. So, why is this? As we've mentioned, one of the most common ways that macular holes form is when the vitreous humor pulls on the retina and tears it, causing the hole. If the vitreous humor, which is normally attached to the retina, is no longer attached, it can no longer pull on the retina. There is no point of attachment, there is no way it can pull. So to sum up, being elderly, being female, being Asian, being myopic, as well as having a macular hole in one eye, increases your risk of getting a macular hole. But if you have vitreous detachment in one eye already and do not have a macular hole, then you're very, very unlikely to get it in that eye. Macular holes progress in stages, and we're going to go through them right here. This is what a normal retina around the macula and a normal vitreous body look like. The retina is completely intact, it's structurally sound. The vitreous body is attached to the retina. In other words, nothing wrong here. In a stage 1 macular hole, the retina and the vitreous humor are by and large intact. However, the vitreous humor already applies some traction to the retina, and what you get are small internal tears that we call cystic spaces. As you can see over here, the retina is structurally intact for the most part, but you can start to see internal tears popping up. However, the vitreous humor is still attached to the retina, and the retina is still by and large whole. A stage 2 macular hole, on the other hand, is where you get a complete tear. All of the layers of the retina are separated at some point or another. However, it's important to note that the vitreous humor is still attached to the macula. It's just that the macula is completely torn in some places. That's what I've drawn over here. This is the vitreous humor, of course. It's attached to the macula, but over here there is a full thickness tear, as opposed to a stage 1 macular hole where you only get partial thickness internal tears. A stage 3 macular hole, on the other hand, is where you get complete detachment of the vitreous humor from the retina. So, as you can see, here's a full thickness tear, just like in stage 2, but unlike in stage 2, where you still have points of attachment between the vitreous humor and the macula, in stage 3 you get complete detachment, at least over the region of the macula. However, the detachment is only partial in stage 3. In other parts of the retina, more peripheral parts, you still have some points of attachment, which I've drawn over here. In a stage 4 macular hole, on the other hand, you get a complete vitreous detachment, both within the area of the macula and outside of the macula. So the vitreous humor has come completely off, it can no longer cause any traction in the area of the retina. Stage 4 macular holes are also associated with a finding called the Weiss ring. You'll see this on a typical fundoscopy. If you can imagine, this is the retina, this is what you'll see, the posterior segment of the eye. This right over here are a few blood vessels. You will see a floating white translucent ring. This is the Weiss ring. This is a sign that the vitreous humor has come completely off. This is important to note because, as we've mentioned, if you have vitreous detachment without a macular hole forming in the first place, then you are very, very unlikely to get a macular hole later down the line. However, if you know that you've got a macular hole already, and you see a Weiss ring, then you know that the vitreous humor has come completely off and you can stage it as a stage 4 macular hole. There are a number of ways to diagnose macular holes, and let's go through them here. Typical patients will have a range of visual defects. These may be metamorphopsia, where the patient describes distortions in their vision. They may get blurry vision or blind spots and so on and so forth. You can also do ophthalmoscopy. As I mentioned previously, if you see a Weiss ring, then you know that the vitreous humor has come completely off. But By far, the best way to diagnose a macular hole is via optical coherence tomography. I've mentioned this in a previous video, and OCT is basically like getting a side view of the retina. You'll be able to see tears, you'll be able to see cystic defects, and you'll be able to see whether the vitreous humor is still attached. Finally, you can also do the Vatzke-Allen test. This is a test where you shine a very long, thin beam of light directly at the patient's retina. Normal patients will see the line just fine. However, if you have a macular hole, you will still see a line, but with a very distinctive break around the center. Why is this? This break corresponds to the light that hits the patient's macula. Obviously, if something's wrong with a macula, you won't be able to pick up light in that area. So a patient will be able to see the line normally because the rest of the retina is fine, but the light that hits the retina does not get picked up, and so the patient ends up with a blind spot, which is perceived as a break in the line. Treatment of macular holes depends on which stage you're at. Stage 1 macular hole can be treated medically. You give them a drug called ochraplasmin, or you can just wait it out. A lot of the time, stage 1 macular holes will resolve by themselves. If you're at stage 2, however, you have to treat a macular hole surgically. The most common procedure is a vitrectomy, where you cut out the vitreous humor and replace it with some other solution. As we've mentioned, the vitreous humor can sometimes pull on the retina. If it pulls on it hard enough, it can cause macular holes. So if you remove the vitreous humor, you don't get that traction, and you're less likely to get a more severe macular hole. Markers of good prognosis include better visual acuity and a shorter duration of symptoms. If you have better visual acuity and shorter duration of symptoms and presentation, you can be fairly sure that the macular hole hasn't progressed too far yet. Loss of the foveal reflex and more severe symptoms are associated with poor prognosis. Severe symptoms can be severe vision loss, very blurry vision, almost complete blindness in that eye, and so on and so forth. So what is the foveal reflex? If you shine a source of light, maybe from an ophthalmoscope, at a patient's retina, normally you should see a bright speck of light. That is your source of light being reflected off of the retina. In people with severe macular holes or other things like central serous chorioretinopathy, you may get loss of the foveal reflex. This is a sign that the disease is fairly advanced. Thankfully, however, recurrence is pretty rare.